What's up, everybody? Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And today I have a very, very special guest. This is Dr. Greg Jones. He is a licensed naturopathic doc out of Arizona. He has a very extensive history in the military where he spent over a 20-year career in the United States Navy. Dr. Jones then pursued a career in aerospace engineering, so mad scientist, before discovering his true passion lied in naturopathic medicine. So I'm not going to get deep into it because I want Dr. Jones to be his own hype person. So Dr. Jones, welcome.
Well, hey, thanks for having me. I'm just glad to be here. When I tell you this morning was a comedy of errors with the video, the audio, I told Lexi I poop this time every day. I miss my morning bowel movement for this show, and then I can't get this going. So there's the stress, there's the anxiety, but I'm very happy to be here.
Yes.
So my journey, man, I feel like I'm in my third kind of life here. So I joined the Navy when I was 17, and I did 20 years, and was mainly in the nuclear engineering space, right? So I worked on submarines and aircraft carriers, and I started off enlisted, and they sent me to school, came back as an officer, and went back to the nuclear engineering world, and did 20 years, retired. And then I was like, well, what do I do? And I started working in aerospace engineering, right? So I've always been in that world, but my actual degree is in biomedical engineering. So I've always had this thing where I felt like I needed to be in this space. And so after about a year and a half in Honeywell, I was like, hey, what do I really want to do? And the background for me is, unfortunately, my mother died of cancer. And I didn't grow up in the functional medicine space and naturopathic medicine space. I didn't know these things existed. So it was like, well, I just thought there had to be a better drug to help her. So I thought my path to helping people was going to be in pharmacy. And so I started going down the path of preparing to go to pharmacy school whilst I was, so I'm going to school full time to take the prereqs I didn't take, well, part time rather, and working full time. And then I got close to doing it, and something just didn't feel right. And almost by accident, I found naturopathic medicine. A friend's sister graduated. I go to the ceremony. I'm like, oh my God, this is what I need to do. And so it was not even a hesitation. I just switched everything over, applied to naturopathic medical school, and the rest, as they say, is history. And that's what brought me here. That family journey and understanding that, there's a better way. There's another way to get people better.
Absolutely. Absolutely. So you graduated from naturopathic school, and then you jumped into like A4M and peptides. Because listen, let's be honest here. They don't teach peptides. And what we do in nurse practitioner school, they sure shit don't probably teach it in ND school as far as peptides go. So tell me kind of like what drew you into the peptide world, and how'd you then like get here?
Yeah. So really, it's a roundabout, because I thought I was going to do orthopedics and sports med. So I actually did my postgraduate training was in orthopedic medicine and sports med injections. So I thought I was just going to be doing PRPs, injections in people's knees and shoulders and all that. And that's what I did fresh out of school. So I didn't know peptides existed or none of this stuff. So I'm like, again, I'm in this, you got the blinders on. Okay, I'm just going to be injecting the rest of my life. This is fun. I like this. And then COVID happened. And that changed everything, because now, people are not out there doing things to get themselves hurt. We're less active. And again, it's like, wait a minute, I don't have a practice anymore. But one thing I did notice, and this is how I got into it, is that there were people who I would inject, and they would fall in these two buckets, right? There are these people who were healthy. They worked out, they ate well, they did all the things we know to be longevity based and wellness based, right? You'd inject them once and they'd be great. They'd heal, they'd recover. Oh my God, I feel amazing. I'm back to doing all my things. Awesome. And then we have people that we'd inject, and they were in the opposite category, right? They lived a very pro-inflammatory lifestyle. So the diet is horrible. They're not working out. Maybe they've got some weight to drop. They're not sleeping well. They're under stress. And we would have to, and it may take 2 to 3 to 4 injections just to get that same level of relief. So while we're kind of on this lockdown, it kind of hit me like, wait a minute, am I doing this backwards? Am I not? I need to get to the foundations of health, get back to what I learned in school. And just so happened, I started learning about NAD, and that led me into peptides, and that led me into HRT. And when things started to open back up, and when I went back into practice, I was like a whole other doctor. It was like, let's talk about functional medicine and peptides and all that. And the injections, which we still do, they became secondary. That became like, oh, by the way, I do this versus the opposite, right? And that's what got me into it. And it's been a journey, and probably one of the best decisions I've ever made to get into the space.
It's awesome. It's awesome. So I met Dr. Jones, I don't know, a couple SSRPs ago. And so we have just kind of become friends. He's got his own podcast and we'll put all his socials down at the bottom. But he's a great colleague in that we share ideas, and that's what this is about, is sharing ideas, or like, hey, I developed this resource here, I'm going to send it to you, or hey, you developed this, or hey, can I pick your brain real quick about this, or send me your practice manager and I'll have my practice manager train your practice manager, and then I'll send you my nurse practitioner and you can train them. So it's great.
Yeah.
Having friends like Dr. Jones is what makes working in this industry amazing. So, all right. Well, I'm super pumped because today we're with it being February and Heart Health Awareness Month, we're going to jump into some cardiometabolic health. This is such an important topic because cardiovascular disease is the number one killer in both men and women. And so we're going to kind of go ahead and kind of deep into it. I'm not going to get too deep into the woods because we have patients who listen to this podcast and we have some practitioners who listen to the podcast. And so we're going to be very easy, very basic, nothing too crazy. Dr. Jones is amazing at analogies. They're my favorite. And so he makes it very easy to understand. So he's a great educator as well as clinician. So let's start jumping in here. So, how would you describe the impact of cardiometabolic health in what we do, and why is it so important?
So it's extremely important, right? Because when you think about, think of the term here, cardio, your heart, metabolic, metabolism, this can be your weight, how your body functions, how your body produces energy, and there's an intersection between the two. And so when it comes down to it, this cardiometabolic health, when it's off, it is literally kind of like the gateway to all the bad things, right? That's your high blood pressure, that's your high cholesterol or dyslipidemia, if you want to get technical, diabetes, especially type 2 diabetes, and actually heart disease. So it's the gateway there, right? And so when someone is in this kind of this negative cardiometabolic state, it leads to a pro-inflammatory kind of conditions, right? The environment, if you will, and very oxidative stress. And, like I said, we don't want to get super duper in the weeds, but essentially think of inflammation as heat, oxidation as rust. It doesn't matter if you're a human, car, piece of metal, that's bad for you, right? And it leads to accelerated aging, right? And this can damage certain systems, and we can talk more about it. But at the end of the day, when it comes to the heart, this causes damage to the endothelium and leads to atherosclerosis, which is kind of that hardening and kind of narrowing of the arteries, right? And so this is where it comes down to it. So if you don't have that cardiometabolic health in place, you're kind of on a slippery slope to really bad health and had bad health outcomes.
Yeah, no, absolutely. I think the biggest thing that we see, we look at different markers as we're like anti-aging kind of scientists, right? I would say cardiometabolic health is crucial because many of those biomarkers are in the cardiometabolic world. So insulin, high sensitivity C-reactive proteins, our A1Cs, glucose. There's so many. So let's start jumping into that. How would you describe the connection between inflammation, insulin, and then rounding it into the cardiometabolic disease?
Okay. So when it comes to the insulin, the inflammation, all that, so I'm going to kind of link some things together here, right? And so the link here to me is obesity, right? Because if you have someone in a pro-inflammatory state or they're insulin resistant, you tend to gain weight. You tend to get more adipose tissue. And so when we think about adipose tissue or fat, you think about just putting the pounds on. It's like, hey, I'm gaining some weight, I've got this, but adipose tissue, fat is just not some storage space for your extra calories. It's just not this, this bin of like chubbiness, right? It actually is an active endocrine organ, which means it secretes hormones and actually gives off these pro-inflammatory proteins they're inflammatory cytokines. You get to call adipokines, but they kind of lead to the systemic inflammation. And that's where, when I talk about that intersection, that's where things go off the rail, because that inflammation is going to impair your insulin signaling pathways, right? Leads to insulin resistance, and insulin resistance leads to diabetes. And so then on top of that, now you're not, metabolizing glucose properly, and that leads to not metabolizing cholesterol or lipids properly. And now you're in this pro-inflammatory state and pro-thrombotic state, and this is where things really, really go bad. And so when it comes to the link, it's just that thread. That inflammation is the thread between insulin resistance and obesity and those cardiometabolic diseases, right? And so when we think inflammation, and this is where I kind of want to break this down, because I think when most people think inflammation, you think about, man, I stubbed my toe, I bumped my elbow, it's swollen, it's hot, it's inflamed. That's a big part of it, yes. But a lot of inflammation, most people, their inflammation comes from the diet, excess nutrient intake, right? And basically, and that's your number one thing. It's like, hey, I'm in a pro-inflammatory diet state. So dairy, gluten, sugar, all the things. I know on some of your podcasts, I know you guys have covered this in depth, but that's the thing I think people miss is like, hey, I'm inflamed, not for something that necessarily is going on, but it's what I'm doing to myself, right? And then you can throw lack of sleep in there, you can throw stress in there. There's all these things in the traditional lifestyle or a normal lifestyle that lead to inflammation. And it's not that inflammation, again, it's not the, hey, I'm stressed out, you may not have my fingers are swelling, but this is that low-grade inflammation that you may not necessarily feel, but you start seeing it as in you're gaining weight, and then, you're starting to get, retaining water and all these different things that come with inflammation. So
absolutely. One of the coolest things that I think that we currently see in practice with some of our GLP-1s or GLP-1 GIPs, you control insulin, you can very much well control inflammation, which is crazy. So this past weekend, I was in New York at the Integrative Health Symposium, and one of my favorite lectures was a cardiologist and a pharmacist, and they were talking about the positive impact that semaglutide has had on lipid studies. And, we think semaglutide, like, oh, that's everyone's skinny shot, right? No. There's so much more that it's doing from an internal perspective. Again, controlling insulin, right? Then you're controlling those inflammatory markers, which then you're going to see some other positive downstream effects. And that's kind of what the name of the game is how can I impact this and see the cascade of all these other really cool things in a positive way. Do you want to add anything to that as far as the GLP-1s and the impact on like LDL? Like I've seen it on our Boston heart tests, the drop in small densities and things like that. Do you want to share anything on what you've seen with it?
Honestly, it's that link. It's that link, So what I mean by that is that link between inflammation, insulin, and heart disease. And so the one of the reasons I think, and obviously some of the research is starting to dive into it because they are noticing this is kind of almost unexpected. Like, hey, this peptide, this medication is for weight and for glucose control, but it's like, wait a minute, people's cholesterol is coming down, right? So what happens is when you're in that hyperinsulinemia state, insulin's not under control, glucose is not under control, that leads to this endothelial dysfunction, right? And so when it comes, let me kind of, this is one of those things like I think sometimes we ignore it. And it's like this big scary term. Oh my God, endothelial dysfunction. Right. And it kind of is. And so really to understand that, I'm going to kind of take this and move it forward, Lexi, is that let's talk about the endothelium. And so basically the endothelium, it's like that innermost lining of your blood vessels, right? And so essentially it's kind of the lumen where the blood flows and you got the smooth muscle. It's a layer in between there. It's a layer of cells. And that endothelium, one of the big things it does, it helps your body produce nitric oxide. And that nitric oxide is how your body controls vasodilation and just keeping those blood vessels nice and open and flowing and things are going, everything like that. And so when you get this endothelial dysfunction, it's like you kind of, those cells shift away from producing nitric oxide, and then now they're producing more oxidative stress. And now you're getting this inflammatory response. And it's just essentially, if you really want to think about it, in my analogies here, if your blood vessels are a network of pipes carrying blood to different parts of your body, the endothelium is like a special kind of control system for that. And so it's like an AI intercoding, right? So it's just not coding it, but it's smart. It knows when to vasodilate, when to vasoconstrict. And when that's not working, those signals that it sends to help your blood vessels expand, they just aren't there. And now you've got high blood pressure. Right. And so this can lead to, you think high blood pressure. So just the end results of that. But what happens is over time, it gets worse and worse and worse and worse. Right. And so now to kind of bring this forward is when you end up in this state where you're, not just endothelial dysfunction, but now the next step in that is you get that high cholesterol. So it's almost like that insulin resistance leads to high cholesterol. So if you can reverse that, starting at the root cause, the inflammation, which GLP-1s are great at, keeping the blood sugar and insulin under control, then you can tend to see that reversal of the high cholesterol. And it's just a really fascinating thing to see how these things play together. And it's almost unexpected, But we also know it's part of a comprehensive program. I know we're going to talk about this later. It's not just, hey, everyone listening, hey, take semaglutide or tirzepatide and all your problems are going to go away. There's work that needs to be done,
Right.
on the patient side of the house.
Right, 1000%. Kind of shifting gears just a little bit is, so one thing that you do a ton in your practice, as we do as well, is hormone optimization. So we can't talk about lipids without talking about testosterone and thyroid and that piece. A couple weeks ago on our Thyroid Thursday, I said, hey, did you know that T3, free T3 has an inverse relationship with LDL? And I had so many patients like, I had no idea. And I'm like, that's why I put it out there. So do you want to talk a little bit about the connection between kind of the other little pieces of what we do and how we tie this into more of a comprehensive approach?
Yeah. So when we think hypothyroidism or suboptimal thyroid, when most of your patients come in, most people get that feeling. It's like, hey, I'm having difficulty losing weight. I'm so tired. I can't think clear. My hair is thinning. I'm losing hair. I feel cold. I'm constipated. I got dry skin, brittle nails, all these typical low thyroid things, right? But one thing that they don't notice is that, or they don't see, especially if they don't have the lab work or their practitioner isn't drawing the link, is that you'll see their cholesterol high and the LDL high. And for me in the lab, sometimes that's almost like my first thing. I get a person's labs, I look at their lipids, and this is the general standard, dime a dozen lipid panel. Wait a minute, you got high cholesterol, you have high LDL, but your triglycerides are normal, actually good. Your VLDL, we'll get into some of these markers later, is great. And I'm like, wait a minute here. Like, what's happening here? Like, you would think if these two are high, why isn't everything else high? And then if I see high cholesterol, high LDL, I go straight to their thyroid. And most times you'll see a very low T3. And you're like, wait a minute here. Yeah, it's like, wait a minute. And they're like, wait a minute, I don't know why this is high. I'm working out. I'm eating clean. I don't know what's happening here. It's because the thyroid, those thyroid hormones, especially T3, they modulate cholesterol production, transformation, and clearance. And so essentially, if you are low in thyroid, then your body's producing more dysfunctional HDL. And when that dysfunctional HDL means it's not doing its job of kind of rumming the bloodstream and taking the bad cholesterol away, when that's not functioning well, you get higher LDL. Right. And the other part about it is those thyroid hormones they are crucial for the expression of your LDL receptors on the liver. So essentially, think about this. This is kind of like if it's like one of those automatic trash cans, right?
Yeah.
And if that trash can doesn't open, the trash doesn't go in. Now it's just floating around the bloodstream. So think of think of thyroid as your hand waving on the automatic trash can, like, hey, open up. I got something to put in here. So if that doesn't work and you don't have that signal, now you have this higher LDL. Does that kind of make sense with that?
Yeah, absolutely. Now the piece of it with testosterone. So always I feel like, and I'm sure you'd get it too, is like, I feel like all damn day I'm like busting myths of like, well, my doctor said this about testosterone. My doctor said this about testosterone. And it's like, listen, replacing your testosterone is actually going to positively improve your cardiometabolic health. It improves insulin sensitivity, which then again, downstream effects can help with your lipid panels and things like that. How would you describe to a patient when they kind of say, well, my doctor says that testosterone's not going to be good for my heart? There's a caveat with that too, because it's like, well, if you done had an MI like last month, sure. Yeah. Like, let's give it a little bit of time there, but I will give you some T3 because that's going to help your post recovery. But I don't you feel that way? Don't you feel like it's like a kind of like, you're always like busting myths? It's like, well,
always, man. Yeah, it's a fight because, and it's frustrating. You'll have patients who you're like, hey, let's, looking at your lab work, your symptoms, all that, I think you'd be a great candidate for testosterone replacement therapy. And then they come back like a month later and like, oh my God, I talked to my cardiologist because they may have a history of high blood pressure. And they're like, oh my God, no, this is going to give you a stroke and cause this, and this. Like, oh my God, you know what you're talking about.
Yeah.
And so,
and then, and not only that, but think about the patients too, Greg, that say they're cardiologists, they're on statins, and now they got low T. And it's like, well, it's because you've now oversuppressed your cholesterol production, which cholesterol is what produces pregnenolone, which pregnenolone, we always say, is like the mother hormone, right? So then you need pregnenolone to convert into androstenedione, which then converts into testosterone, which that is leading why you have low testosterone is because potentially the statins you're on or whatever cholesterol medicine you're on. So it's like a vicious cycle, right? It's like a vicious cycle of like, well, we got to fix you somehow, right?
Yeah, and it's unfortunate because, again, and I'm not taking a big old this is not a chance to, elbow drop on the top rope on cardiologists,
No,
because there's a lot of great
no.
cardiologists out there, and we know
Absolutely.
quite a few, even from with SSRP. We know some great ones that are able to
Yeah.
think outside of that box a little bit, right? So kind of going back to the lab work here. So again, sometimes if I'm, a lot of times, if you look at the LabCorp report or the Quest report, they'll go CBC, CMP, cholesterol. You got to keep scrolling. Eventually you'll get to your hormones, right? It's so down the list, right? You're going to get to everything else before you get there. And so one thing I'll see with low testosterone, it's similar but not the same as with the hypothyroidism, is that I'll see a higher LDL and a low HDL.
Mm-hmm.
And that's like my little, wait a minute, like you got good cholesterol, high LDL, low HDL. Scroll down, look at this. You got a 300 testosterone and a 4.3 free testosterone. Like, all right, here we go, right? And so, and what it comes down to it is that when you actually look at the research on TRT, it's actually been shown to improve cholesterol profiles, because it actually decreases the total cholesterol and the LDL and can increase the HDL. So it's not omega-3s, it ain't going to increase it like that, but you'll see that profile shift. And so I have this really cool PowerPoint, and Terry Horgody, I don't know if you're familiar with him. Of course you're familiar with Horgody, right? He's written the giant Bible on hormones, right?
Yeah.
And there's a presentation that one of my mentors shared with me, and it's many, many years ago, but it's still applicable. And it looks at all the levels of testosterone. I definitely want to share this with you. It is when I say it's my hammer, when someone's like, I don't know about this, right? And it breaks it down. It's kind of a complicated slides to break down, but you'll have no problem with it. It looks at levels of testosterone and what chronic disease risk are exacerbated when your testosterone is low. Now, when testosterone in this paper, it's such a cool PowerPoint. I wish I could do some B-roll or something like that. So when testosterone is greater than 900, so not excessive, right? We're not talking like 15, 1600, like, that level. But that's kind of like, that's for me, that's why I always shoot for around 900 for my baseline when I have a guy on testosterone replacement. Because above 900 total testosterone, the studies show there's a lower risk of high cholesterol, dyslipidemia, arterial sclerosis, high blood pressure, and obesity, because testosterone does help build muscle and help you lose fat, right? And so if I can, just that right there should be enough to say, hey, you know what, this is something that can optimize not just how a guy feels, but also their long-term health outcomes.
Right.
Yep.
Yeah,
so that's
I think that's awesome. All right, so let's talk about maybe some of the preventative measures and lifestyle changes that we typically recommend to our patients. So there's, I think you and I in our practices, I say the big sexies. So those are like peptides and pellets and ozone and NAD and all kinds of stuff. It's like, well, let's not forget the basics: sleep, what you put in your mouth, how you move your body, lift some damn weights, making sure you're recovering, all those things. So what are like some of the basic things you tell your patients to improve endothelial dysfunction, improving kind of your cardiometabolic kind of milieu in your body?
So this is where the engineer in me comes out, right? Because I tend to think very since I almost systemically and almost in this order. So for me, the first thing I look at is, okay, what are the risk factors, right? If I'm looking at the long term, like, okay, the things you said, obesity, endothelial dysfunction, what are the risk factors? And I go after those top, 5 or 6. So high blood pressure. So let's see where you are. You coming to your vitals. Like, because that's a big clue right there. It's like, okay, and it's not the white coat syndrome. Like, I check it at home. It's been high. I've been dealing with it for years. I go after insulin resistance. So you check their glucose, their fasting glucose, for HbA1c. You kind of say, hey, when you eat oh my God, I eat carbs and I blow up like a balloon. All right, that's not good. We go after obesity. We go after weight, and not just weight. It's not the scale, because obviously we want you to you want muscle, right? So if it's like, hey, I'm a little bit bigger in muscle, but I'm lower in body fat, and that's where that in-body scan comes in. That's great. Are you sedentary? Are you just not working out? Huge risk factor for these things, right? And there are some of the lifestyle things, right? Like, are you under a lot of stress, right? Are you smoking? Which, okay, man, I can't believe people are still smoking with all the research out there on tobacco, right? But people are still smoking, and we try to help them navigate getting off of that. And then alcohol, right? And just alcohol abuse, right? So drinking a ton of alcohol, this is the daily bottle of wine every day kind of thing, right? And we go after that because, again, if you don't establish that foundation, like you said, I can throw all the peptides in the world at you. I can get your hormones optimized, but if that foundation is not there, we're swimming upstream.
Right.
And so then we go after what else now we got the foundational stuff. What can you control? And to me, we always start with those external factors, the things you directly can control. You can control what you're eating. Right. And so when it comes down to it, if you're eating a diet good in, high in vegetables and fruits, but kind of more the low glycemic index fruits, lean proteins, healthy fats. So essentially some, modification of the Mediterranean diet.
Right.
And I say modification because, it's going to be cultural, right? Because I had I got, one of my patients from Southern California, and I was like, hey, I got this Mediterranean diet. You're going to love it. He's like, dude, I am from LA. This ain't it. Is there a Mexican version of the Mediterranean diet? I'm like, well, kind of. Let's just modify it, right? So
I was going to say, so chicharrones aren't on that diet, just so you know.
Yeah.
Chicharrones are pork rinds. Yeah. Mexican here. I understand.
Yeah. So you kind of, so you want to make sure that, you can, have that. Don't just say, hey, I'll put you in this box. You got to eat this, right? So make sure it kind of meets where they can go. The next thing is another thing you have control over, you can work out. You can lift weights. So not just, there's not just let me get on the stair step for a half hour, but actually doing some resistance training, because that does help improve insulin resistance and the lipid profiles, right? And then managing your weight. And there's so many factors there. And this is where all those first three things we said do help. But we have the other tools. We have peptides. We have GLP-1 agonists. We have other peptides that are great for that. We have supplements that can actually help improve metabolism, right? And so when I do talk about weight loss, I tend to talk more metabolism, because I think weight loss kind of sets it almost like an unfair expectation. Like, there aren't many things you can take, like, hey, take this, you're going to lose weight. Right. There's other factors that need to go into it. Right. It's almost like a barbecue grill. Right. The supplements, all that stuff, that's your charcoal or your pellets. I got my Traeger grill. Shout out to Traeger, man. I am a chef these days. Right. And so I'll give a shout out to them real quick. So, so that's just that's the kindling. That's the thing that you need to light. But the things you do, you're working out, your habits, your lifestyle, that's the fire. And that's the lighter fluid if you're using an old school grill, right? You need to light that fire to help those things work better. And then also things, smoking cessation and decreasing alcohol intake, moderating that, managing stress. And then I know you can do a whole podcast on stress management, because that's so difficult. But that's the start. That's the foundation. Those are things you can do right here, right now, today, tomorrow, day after.
Let's talk a little bit about some of those advanced testing. So you go to your regular doctor, they'll do like your regular total cholesterol, LDL, HDL, and triglycerides. All right. So let's shift gears a little bit. And I'm going to ask you some of the advanced cardiometabolic testing that you do. First one I'd like to ask is lipoprotein A, or LP(a). Why would a patient consider checking that, and what is that going to help us as their practitioner guide their therapies?
Okay. So I'm going to, I've been doing a lot of these roundabouts. So you ask me a question and I get to the answer. I want to do this. I want to start with this because, again, most of our patients, especially when they come from their PCP or they're, coming from the traditional kind of healthcare model, they've got lipid panels, right? So they got their basic panels. They got their cholesterol, the LDL, the VLDL, the triglycerides, and that's great. It's a good foundation. It's a good start. It's the beginning of your journey. But the issue is if you look at the research, depending on where you read it, 30 to 50% of heart attacks and heart disease has normal cholesterol. It's missing the mark, right? Because it's just a count. It's a big start, but it's not talking about the risk factors and all that. So for us, we look a little deeper. And one of those, I hope we get a chance to talk about something, because this is like one of my favorite things. And I feel like I was like, Eureka, I got it. I found this. I mean, I feel like I discovered, a new country looking at these labs, because again, even in school, we're taught, very surface about this, but how to actually interpret this and use it in practice. So LP(a), it's a lipoprotein. So basically you think about lipoprotein. So it's like lipid and protein together. And it's more of a genetically determined thing. So this one's hard to bring down, but it kind of tells me like, hey, genetically, and also there's some lifestyle involved, but you have a higher risk of atherosclerotic disease, right? And so it's kind of similar to the LDL, but it has an additional kind of APO attached to it, the apolipoprotein A, hence LPA. And that LPA is actually very prothrombotic. Right. And so when we talk about like strokes and clots and all that, and that's a big one to look at, because that's like, okay, that's high. We got to take this serious. No matter what your cholesterol panel says, we got to really dive into how to keep you in a very healthy state of mind with inflammation and oxidative stress.
Yep, absolutely. So what other advanced markers are you looking at in your practice?
All right. This is the fun part. And so some of the markers we look at, and I was like, when we were talking about a question, I was like, I'm so excited to talk about this. It's like my favorite thing because I feel like I do talk to patients about it all the time. All right. So sorry, my speaker is doing bad speaker things here. So I'm going to take a breath. And when you do your post editing, you can kind of get into that a little bit. Okay. So let's talk about what you see on your traditional panel and then what we want to look at. So let's talk about LDL because we've talked about this a few times earlier in the podcast here. So LDL, or low density lipoprotein, is often, we think it's the one we say it's the bad cholesterol, right? And I think that's a slight misnomer there because not all cholesterol is bad. It depends on what's going on with it. So that LDL that you get, in your traditional panel, that is, it carries cholesterol to all the cells throughout your body. So it's kind of like a transporter, just kind of circulating here, right? But the thing about it, now this is where that good bad thing go. Not all LDL, they're not all the same size, right? So some of them are large and fluffy, some of them are small and dense, and then so small dense ones, also called small dense LDL or small LDL, those are the more dangerous ones, right? Because they have a bigger risk. And I talked to my patients about it, they're like, wait a minute, I thought, why is a smaller one worse than big? Big seems like it'd be bad because it shouldn't just cause like a blockage in the artery and your blood's not flowing, but it's really not the same. So let me kind of expound upon that. Those small particles, because they're so small and dense, they actually can penetrate the endothelial layer and they can get trapped in there, right? And when they get trapped, they can form plaques. Right. And so because they're small and they're denser, they can be, they can be retained or kind of stuck to that wall more. Whereas, and also they're more prone to oxidation because they're smaller size and all that. That makes them more likely to start inflammation on those bad pathways you talked about earlier. But those big ones, those larger ones, they're so big and fluffy, they kind of just bounce off, right? They just kind of bounce off the wall and they just don't get oxidized. They're just like a big old, like in the Macy's parade, they're just kind of floating around, bouncing off and just minding their own business. Hey, HDL, take me away, right? Yeah. And so that's the biggest thing. Now that's the confusion, right? Because when people talk about LDL, that LDL that you see in your traditional lab, that's just the amount of cholesterol in the LDL particle, but it's not the number of particles, right? So you can have a normal LDL and a high LDLP, especially if that LDLP is small and dense, and that's a higher risk, right? So is that something you guys see in practice? For yourself,
absolutely. Too? So I like the Macy's Day Parade analogy. I got one. So you originally from Chicago, aren't you? Midwest. Okay. Potholes and the winter, right? So small, dense LDLs, those are like your little potholes and they start to get bigger and then you get gravel, it gets stuck in there. And then that's how you got plaque. So you got like a pothole and that's your plaque. The way I describe it is that you've got these little tiny particles, they get stuck and then you get the plaque buildup. And then when those things break off, that's where you get those clots, right? The other thing that we also look at is ApoB. So ApoB, you have those tiny little pieces of plaque. Well, the ApoB part of it is our cardiovascular risk. That makes those little plaque particles sticky. So you don't want sticky little plaque particles. You don't want sticky LDLP small dense because now you've got gum stuck in the pothole in addition to all the gravel and all the other crap that got caught into the pothole. So that's what's making it worse. So we look at ApoB, which is that sticky piece. LP little a or lipoprotein A, which is the inherited genetic plaque piece of it. And then you've got those small density LDLP numbers, which is how little are the little ones. And it's like, oh shit, we got too many little ones now. So that's the way I look at it, is from a couple different angles. One test that we do in our practice a lot of is called the Boston Heart Test. And there's lots, there's like the Cleveland Heart, Why I like the Boston Heart Test in particular is because like you, I'm not one to just throw people on medicine and be like, all right, there's your Lipitor, have a nice day, right? If I'm doing something, I want it to be as precise and as down to what the particle and what that patient's body is going to do with it as possible, because I need it to make a big impact. So we do two things with cholesterol. We produce it in the liver and we absorb it in the gut, right? That's what we do with cholesterol. And so what the Boston Heart Test does is it actually looks at what they call a cholesterol balance sheet. And so it breaks it down. Okay, here's your production markers, and it looks at lanthosterol and desmosterol, which are your producers by the liver. So if you are an overproducer, that's where your statins can be helpful, and like your plant sterols and things like that. And we're going to get into the supplements. However, let's say your LDL comes back high, but you're not an overproducer. Let's say you're an overabsorber. Really, Zetia or like red rice yeast is going to be a better option because it's going to help your body not absorb so much of that cholesterol. So it'll look at things like beta cysterol and I think it's called campisterol. So it's actually looking at, are you overabsorbing it? And if so, which one? Because that's going to help me as the practitioner know what recommendations do I need to make to impact specifically what your body is doing. So that's why I really like the cholesterol balance sheet, is because it makes it a lot more precise for the patient. Love it. That's the other, like, in addition to what you are also doing, that's probably the other little piece of it that we also add in there as well.
I love it. And then we were kind of talking about that. I was like, man, I got to look into that one because that's one we're not in. Some of the labs I'm going to talk about here in a second. I think pairing it with what you're doing with the Boston Heart could be really, really cool. So, and the next one I want to kind of get into is HDL. Now, HDL, a lot of times we say that's the good cholesterol, and that can also be a little bit misleading because not all HDL can actually, and we'll get into the dysfunction of it here in a second. So HDL, or the HDL-C, when you get in your traditional lipid panel, that's kind of the amount of the cholesterol that's carried by those high density lipoproteins, or HDL. And they call it good because it helps remove other type of cholesterol out of the bloodstream. So especially the LDL, right? And so HDL, it's like a bus, like a school bus, right? So it's like running around, picking up the kids, picking up the bad kids, right? The LDL, taking them to the liver. This goes down to that thyroid thing around that automatic trash can thing, right? Opening up, dropping it off. And so then it can be processed and eliminated, right? And so in general, higher levels of LDL are generally associated with lower risk of cardiovascular disease, and that's based on understanding that HDL is kind of like that ability to remove cholesterol or reverse cholesterol transport, which is actually getting cholesterol out of the body versus maintaining it or sustaining it, right? And so, but here's the deal: you can have too much. You can have too much. Okay, I'm going to hold on one second. I got to pause it. Okay. So with that being said, when that HDL is too high, it's almost like I said, like the bus is almost it's too many buses on the road. Right. And so when there are too many buses on the road, it's like they're just kind of, it's a traffic jam. They're not picking up the kids, they're kind of stuck. And this is called dysfunctional HDL, right? So when a patient's like, oh my God, my HDL is 120, I'm like, that's not good. It's not good. It's too much, right? It's a little bit too congested, right? And so, but that being said, then there is a distinction between HDL-C and HDL-P. So again, that HDL-P kind of measures the total number of HDL particles regardless of that cholesterol content, right? And so the theory is that the HDL particle is a better predictor of risk than the actual cholesterol HDL-C, because no matter how big the particles are, or the amount of cholesterol they carry, they can actually help you get cholesterol out of the bloodstream, remove that cholesterol from your cells and tissues, especially the arterial walls, right? And so, but then there's more breakdown, right? So you have the HDL particle size, but then they have two kind of subtypes that we like to check as HDL2B and HDL3. So HDL2B, they're the big ones, right? These are I call them the party, but those big party buses, where people going around, there's a party on the inside. They're the fun ones, right? They're the biggest and most buoyant. They're rich in cholesterol. They can carry a lot more cholesterol per particle. And they actually are really effective in that reverse cholesterol transport, where the cholesterol is removed from the tissues and arteries and going back to the liver for excretion, right? It's kind of like, hey, it's a party, but we're taking you away. So enjoy this last ride, right?
Yeah.
And so
last call.
Last call. That's your last call. Right? It is. So then there's HDL3. These are, in that transport kind of analogy, the HDL3, that's like the limo. That's like your stretch Hummer. People still have stretch Hummers. Oh my God, I'm showing my age, right? That's your stretch Rolls Royce, all that. It's big.
I don't know. That's a good question.
Yeah. So, so they're great. They're not as big, right? So a little bit smaller, right? And they're a little bit more dense. And so they have a little less cholesterol, but they're higher in this protein called apolipoprotein A1. Now, even though they're smaller and they have a lower lipid content, lower lipid content, they're actually very good in actually that reverse cholesterol transport. And the other thing about them is because they're a little smaller, more dense, maybe they can actually get into that endothelial layer and take that cholesterol away from those macrophages in the wall. So that's actually really cool. So even if you got to a situation where you had some LDLs, they kind of got stuck in there because the HDL3 is a little bit smaller, you can actually get in those tighter spaces and get that cholesterol out of there. And that's really, really cool. So the next one, and I know I'm flying through this because I don't want everyone falling asleep, but I think this is so important, is VLDL. And that VLDL is a very low density lipoprotein, right? And so again, traditional panels, it's an indirect, it's more of a calculation, right? And so most of them will say it's your triglycerides divided by 5, because the assumption is that most of the triglycerides are carried by the VLDL. So it's a good estimation, but it doesn't really give you all the information you need. And that's where we want to look at the VLDL-P, right? The number of VLDL particles and actually the VLDL size, right? And so again, with a higher number of particles, that's more risky because those VLDL particles can convert to that small, dense LDL we talked about that's more risky. Mm-hmm. But also, the other reason, the larger VLDL size, that's a little more riskier because they actually are more efficiently converted to LDL. Mm-hmm. And that LDL can actually infiltrate the walls and form plaques, right? And then also, if you have a larger VLDL, the theory is that it's carrying more triglycerides, and that can also be a risk factor as well. And so if you put that all together, that's how you can actually look at these and see these numbers and say, hey, where's the risk, right? Because you'll have patients where it's like, hey, I'm kind of borderline high with my cholesterol. My PCP wants to put me on a statin. I run this panel, and it's like, you're not at risk, man. So you just keep working out, eating clean, doing all the things that we're doing, and you're in a better place to be, right? Right. And so that's kind of the big thing. And then I got one more, and I'll let it go. I know I'm going a lot because the fascinating thing is LP-PLA2. Oh, that's when it comes to assessing your risk factor long term, super important because that's actually an enzyme. So it's not a cholesterol marker; it's an enzyme that's actually going to oxidize that oxidized LDL. It's going to hydrolyze that oxidized LDL and kind of lead to that pro-inflammatory and higher oxidative stress state. So essentially, if you're high LP-PLA2, it's like if it was a stick of dynamite, the ApoB and the LP-PLA2 they're lighting that stick of dynamite. They let you know, like, that's not even, sorry, let me say it a different way. It ain't about to be lit. It's already lit, right? And so it's a matter of how long the fuse is. And that's what we want to do is kind of either put that out or say, hey, let's work on making changes before that fire gets closer to the stick of dynamite being heart disease. Right.
Yeah. The way I describe the LP-PLA2, it's like the marker of a blockage about to happen. It's like just ready any minute now. This blockage is about to happen. And so, that is definitely something we look at as well. All right. I think we covered all of our in-depth testing that we do. Do you want to talk a little bit about some of the supplements that we find helpful?
Did you just ask a naturopathic doctor if they want to talk about supplements? Why, yes. Could never.
Making sure that's next on the menu.
Why, yes, I will talk about supplements. I will do that all day. Even if it's like no one, and those memes, no one, and then it's like naturopathic doctor, man, did you know omega-3 does this? That's what we do. So jam, right? And so my top nutraceuticals or top supplements for cardiometabolic health and cholesterol. And this is that engineer in me, right? So if I'm looking at these supplements, what in that advanced lipid profile and those cardiometabolic factors does that supplement address? Because again, I don't want to give you a million supplements. I want to give you the right supplements that are going to address what's abnormal, what's risky, right? And that's how I think about these. So the first one, omega-3s, right? Standard. Everyone knows take fish oil, although we know all fish oils are not created equal, right? Because there's crappy ones out there. You got to look at the source because they can be ranked. They can just be low quality. But a good omega-3 is going to be high in EPA and DHEA. Mm-hmm. So not DHEA, DHA, which is an important distinction right there, right? So I was taking DHA for my cholesterol, and I was like, no, you're taking 100 milligrams of DHEA, and now your DHEA is 700, sir. So let's stop that. So EPA, DHEA, they're crucial for that cell membrane fluidity, so allowing the cells to function better. They actually lower triglycerides, and they're also very anti-inflammatory, good for brain health and heart health, kind of things if you've done any reading on omega-3s, you know that. But when it comes to those panels, omega-3s are very good for reducing triglycerides, VLDL, LDLP, they increase HDL and HDLP. I'm sorry, let me do that. Sorry, one more. Let me kind of refresh it because I know sometimes getting the particle number and the particle size can be confusing. Omega-3s kind of lower the LDL particle number, but they can actually increase the LDL particle size, which is great. They're also good for increasing the HDL particle size as well. That's my number one. My number two, which is, it kind of fell out of favor, but when it comes to the things it can do for cholesterol, niacin. Niacin it fell out of favor because there were some studies. Oh my God, niacin oh my gosh, it's causing, liver damage, and it's causing all these issues and the flushing and the paresthesia and all that. It's just that when they did some of these studies, the dose was so high. It was like 3 grams of niacin. I'm like 2-3 times a day or something crazy like that. I may have to look that back up, but it was a really high dose where a lot of times in practice, we're doing way less than that. Way less than that. And we're doing more of a control release because, again, you don't want to get all that niacin at one time because it can be very uncomfortable.
Right.
So with niacin, improves endothelial function. I love that. And then it also has an impact on the enzymes that are involved in lipid metabolism. But really, when it comes down to it, when I think about the factors that it does, it lowers total cholesterol, LDL, ApoB, LDL particle number, triglycerides, VLDL increases. This is really cool. The studies show niacin actually can increase those small LDLs into larger type A's. So it can actually make those small LDL particles big enough that your body can, get them out of there, right? Increases that HDL2B and the ApoA1. That's your type HDL3. Increases HDLP and can lower LPA. So that's almost everything. So niacin, just like I said, man, it's like when I may start, depending on where the person is with their lifestyle and their lives, I may start them on omega-3s. We come back, needle ain't moving. I may say, let's do some niacin. If the needle ain't moving then, which usually it does, or I may reverse this, I say, hey, let's do red yeast rice. Red yeast rice contains that monocolin K, and that's literally what makes statins work. But red yeast rice tends to have less of the side effects. So with the muscle soreness, the risk of rhabdomyolysis and some of the lowering CoQ10, you still have to worry about that if you're higher doses. But what I really love about niacin is that it can actually lower the LDL-C, lower the total cholesterol and the triglycerides, and actually increase HDL2B. So it's like, hey, this is a safer way to use this, or a safer version of a statin, or a natural version of, right? Yeah. So 3 down, 2 to go. I'm getting there. So I told you, you asked me about supplements, and this is what happens, right? So the next one, aged garlic extract. A big fan of that because rich in antioxidants, has been shown to reduce blood pressure, inhibit that platelet aggregation, so reduce the risk of blood clots, all the good garlic things. But it doesn't taste like garlic, and it's not really kind of that burning that you can get if you take a high dose garlic supplement, right? And so really good at lowering cholesterol, reducing oxidative stress and inflammation. And so it can lower total cholesterol, lower that LDL, decrease ox-LDL. We didn't get into that. Maybe we'll do a part 2 and talk about ox-LDL. From an inflammation standpoint, high sensitivity CRP, which is another factor that we can get into maybe in a part 2. See how I'm plugging for a part 2 here. And last but not least, this is one we don't see as often, but I've had some great success with, is tocotrienols.
Oh, okay.
And so tocotrienols, depending on what part of the country you grew up in, they're members of the vitamin E family, and they're very great antioxidants, but they also protect against lipid peroxidation and oxidative stress, right? And so that's how they do their antioxidant properties, right? And so what they do, very similar to, did I just get a thumbs up on there? That was so weird. And so very similar to the red yeast rice, they inhibit that HMG-CoAce activity. So HMG-CoAce reductase, what they're suppressing, which is similar to statins and how they convert into cholesterol, right? And so that can help with reducing arterial stiffness and improving endothelial function. So from a lab perspective, tocotrienols are good for lowering ox-LDL, lowering the LDL-C, lowering the LDL particle size, and actually helping with LPA, or LP-a. All right. So those are like my, again, it depends on the case there. There's different combinations you can do with that to make it work. But I want to talk one more thing and then I'm done. Timing. I know I keep saying that and I keep going, right? Timing, right? And so I actually, when I do have a patient on red yeast rice, I recommend they take it at night. And they're like, wait, I got to take it at night? Because your cholesterol synthesis, how your body makes cholesterol, it has kind of that panel, and most of it
Mhm.
happens at night. So you make more cholesterol at night. And if you want to get too technical, it might be because you produce more bile acid in the mornings. That's the opposite at
Mhm.
night. But really, when it comes down to it, is that, in my opinion, some of the research I've done is that it's when the liver works.
Right.
Your
Yeah.
liver, where is the primary site of making cholesterol, that cholesterol synthesis is less active during the day, and it switches to this anabolic state at night, this repair state, which makes sense because at night is when you're producing hormones. You should be making growth hormone. You should be making testosterone. And your body's like, hey, I need the building blocks, which is
Right.
cholesterol. So now you're making more cholesterol, right? And so if you're already in this state, this is why I tell people about eating at night, because you're already going to make more cholesterol at night just being healthy. And now you're going to eat and kind of add fuel to that fire, and that may lead to the overproduction of cholesterol. So I think some of the anything that's kind of a HMG CoA reductase. So sometimes we'll do the tocotrienols at night. Say do your red yeast rice at night. I think that's the more optimal way to do it. And I'm done with that. Thanks for
That's awesome. That's great.
Very random TED talk you just.
It's good. It's good.
Walked into.
What's interesting is, we do Boston Hearts, and I actually, aside from probably the niacin, I don't really use too many of those, which is great. It's like I was making notes. I was like, okay, man, I'll start adding that in. We do bergamot. We do a lot of bergamot.
Yeah.
We do some CoQ10. We do Vascanox, which I don't know if you remember, Greg, when we're sitting next to each other at A4M, and I was like, here, take this. It's going to help your focus.
Oh, yeah.
Well, it's like after lunch, and you're like throwing it in your mouth. You're like, oh my God, is there garlic in here? I'm like, just take it. It's fine. You didn't even ask. I just threw you the 2 pills. I was like, here, take this. But Vascanox. So one thing that, like I was telling you the other day, we're going to start doing is assessing nitric oxide in our office. We have these little test strips now. And so Vascanox is another way to improve the endothelial dysfunction as well. It's got a little beetroot in there, which, as you know, being a naturopathic doctor, beets increased nitric oxide. So there's that. And then arterial cell is another one that we do to improve the glycocalyx of the arterial wall. So there's that. Awesome. But yeah, I like yours too. I'm gonna start flavoring it up a bit and start doing it there.
Oh, there's so many more, man. We could have went down the road of berberines and all kind of cool stuff. But again, we top 5. There's like
scratch the
so
surface.
many. I know.
Okay. All right. I think I'm looking through all my notes here. I think that's pretty much everything I wanted to achieve and accomplish on this podcast episode. So it's great. So, Greg, where can people find you if they want to hear your podcast? Because you have an amazing podcast that I've been very fortunate to be a guest of. Your Instagram handle, your socials, where can we find you?
Yeah, so the podcast that I host is the Dr. Jones Optimization Academy. It might be Dr. Greg Jones Optimization Academy. It's a very long name.
It's Dr. Greg Jones, by the way. It's okay.
Is it? Okay. It's a long name. It's like
it's Dr. Greg Jones.
Derek Zoolander School for Kids that can't read too good. It's kind of like that, right? So a very long name. I need to shorten it, right?
I'll tag it.
Thank you. Thanks. I appreciate that. And then Instagram under at Dr. Jones _ Dr. Jones, all spelled out. Same thing. If you look up our clinic, Innovative Wellness Center, you can find our Facebook page and our website and all that good stuff. So try to have, some good content out there. We're starting to blog more and do more short form videos. So education is key to getting people to know about the things we do and being
awesome.
Just things they can take control of themselves.
I know that we have practitioners who listen to this podcast. So are you speaking anywhere coming up this year? And where can people find you on stage? Dying on the inside, but looking so calm on the outside. That's another thing about Dr. Jones that you will never understand is that he's an amazing speaker, an amazing presenter. I've seen him speak so many times, and he looks like he's just like in his element. On the inside at breakfast, he's eating like 10 pounds of blueberries, and he's like, I'm just trying to stay calm. I'm like, what?
Exactly. I need the stress to happen. All these good things, right? Because there's certain things I can't eat and get on stage just for the sake of being focused. But end of the day, man, it's really about just trying to express it and all that stuff. And I love talking about this stuff once I go. So there are some TBDs with speaking. I know that there's an upcoming peptide conference with SSRP. I may be speaking at that. I believe that's in June. That's going to be TBD because I really haven't really locked anything in yet. There's a pilot that you follow my Instagram and all that stuff. You'll see it. There's a pilot for a web series on optimizing health and longevity that I'm supposed to be doing really quick. So there's some things in the pipeline. I just can't really officially announce them yet, but you'll see my mug a lot more this year
That's good.
and last
It's
year,
good.
hopefully. So thank you.
Awesome. All right. Well, thank you so much, Greg. And yeah, we hope to have you on again.
Yeah, I appreciate it. I hope so. Hope so. The people will let you know. They're like, don't ever have that man on there again.
Stop.
You hear that? Don't let me know. I don't want to cry.
No.
So no, but thank you for having me. It was a real pleasure, an honor and a pleasure and a privilege. And I can't wait to see you again.